I'm just going to go through one case discussion. If I can ask all the panelists to switch the camera on, I'm going to share the screen. And because it's Chris's case, I'm going to ask Chris to present it, and I will share it from my end.
I'm just going to take you through some of my thought processes surrounding a rather difficult case. This was a 22-year-old nulliparous but sexually active woman who was referred to me with recurrent, uncomplicated urinary tract infections. She'd had them since she was a child. We'd had numerous investigations, including an ultrasound scan and a flexible cystoscopy, all of which have been normal. She had had long periods of antibiotic prophylaxis as a child. She symptomatically reported fever, which I think is a very good indicator towards whether a cystitis has an infective origin. And she reported a good response to antibiotics, but they only had an effect for a week or so, and then the infections would return, or the symptoms suggestive of them. She was, at the time of referral, taking Prophylactic, 250 milligrams once daily. And in the previous 2 months, she'd had 3 positive MSU samples, all of which were an E. coli, which was resistant to Prophylactic. So my initial plan when I saw her was to stop the Prophylactic and discuss alternative prophylaxis. Now, obviously, my talk will highlight that there is good data surrounding non-antibiotic options, and that was my preferred strategy with this patient because she was already multi-drug resistant at presentation. The next slide, please. So she decided to try methenamine hippurate, which is the urinary antiseptic I talked about, 1 gram orally twice a day. And I saw her again after 3 months. She said she'd been very well for the first 2 months following methenamine, but her infections are now returning, and she'd had 2 courses of treatment dose antibiotics in the last month. Both of those were associated with positive midstream specimen of urine samples, but it's interesting to note that obviously the phenotype here of the E. coli has changed. It's now multi-sensitive. So the avoidance of antibiotics for just a short period has allowed a change in the urinary microbiome, particularly in favor of this multi-sensitive E. coli, which, you know, I felt much more relaxed about given the 4 common antibiotic options I had to use for breakthroughs. She was at that stage, firstly starting to associate these infection episodes with intercourse, but because the methenamine had only worked for a period of, say, 8 to 10 weeks, she was seeking an alternative prophylaxis. So I'll take the next slide.
Chris, can I ask you here,
yeah.
What of the strategies then do you apply is to swap between antibiotic prophylaxis and non-antibiotic prophylaxis to avoid buildup of long-term resistance?
Yeah, I do worry about rotating antibiotics. I mean, I'd be interested to hear the views of the microbiologists, but my personal view is based on some data from ITU patients with rotating prophylaxis for chest infections. They got resistant a lot quicker than the ones who were on the monotherapy. So I do worry about rotating. I think swapping between antibiotic and non-antibiotic prophylaxis is absolutely reasonable. And I think this case, in effect, demonstrates that you can change the urinary microbiome quite quickly. And I think, you know, we've avoided antibiotics in this case, and she's now predominantly growing an E. coli, which is sensitive to Prophylactic and pivmecillinam, as it was resistant in the past.
And this is brilliant information. Can I just ask of the members of the panel, does anyone else? So I'm going to start doing it. I have to put my hand on the heart and say, I haven't yet done this way, but this is a good strategy. So swap between antibiotic prophylaxis and non-antibiotic prophylaxis if it works in the short term. Does anyone else do it? Any other views in the panel? Okay, I'll name and shame then. Zafar, what do you think?
Sorry. Yes, I think the lower the antibiotics, the better. And rather than rotating as much as you can keep a patient on a non-antibiotic option is better, I think.
Okay, fine. We'll carry on, but we'll come back to all of you, all the panelists then.
Okay, so she came to me again and she talked about how the benefits of the non-antibiotic treatment, specifically with reference to the MSUs that I've I've detailed, and she wanted to know the evidence for other antibiotic options. So I talked to her about D-mannose, and I showed her the Crancheck trial, which I showed in my talk, and she then self-sourced D-mannose and took 1 gram orally twice a day. I rang her up after 6 weeks, and she was in a bit of a state. She was in hospital at the time with quite a severe urinary tract infection. The urine specimen had shown the same E. coli it was previously grown, multi-sensitive, but obviously she'd lost faith in the D-mannose after a short period, so she wanted an alternative. I'll take the next slide.
Thanks, Chris. Chris, I'm sorry. Can I just pick up some Manish, if I can get you to comment? So, I mean, in the UK, I mean, a lot of us do try non-antibiotic prophylaxis. And I know that in India, sometimes patients present a little bit late. What is the strategy there? Do you try non-antibiotic prophylaxis, or because they've already sometimes tried homeopathic or other medicines, you go straight to antibiotics?
So, no, I would not be able to talk about all of India, but in our hospital, we do not go on to non-antibiotic treatment as of now. But what we very extensively do, especially what we have seen in these young females who present with recurrent UTI in childhood, is make a search for bladder and bowel dysfunction. And I will challenge Chris about one of the papers he quoted where he said an increased fluid intake is associated with reduced incidence of UTI. But what is not often looked at is the fact that an increased fluid intake results in stasis in the bladder for longer times. It is not socially opportune to go and empty your bladder all the time. So what we have seen is try to keep the bladder empty, try to keep the bowel empty. Constipation is very often associated. I'm assuming all this has been ruled out. And with that, with these lifestyle changes, which are not given due importance in a lot of papers, we have managed a lot of women with recurrent UTI. No drugs at all.
Okay. I'll go on to the next slide. There we are, Chris.
Okay, so at that stage, the patient wanted to try intravesical glycosaminoglycan replacement, and the product we use locally is something called iAluRil. She came for installations once a week for 6 weeks, and then we review as we always do. She thought the frequency of her infections were the same. It had been unaltered, but they were less severe. She'd only had one single positive MSU during the 6 weeks of intravesical treatment, and it again was the same multi-sensitive E. coli. So she decided to continue with that treatment for the moment. Okay. Next slide.
Thank you, Chris. Abhishek, what do you do in Nadia? Do you try intravesical treatment of some sort? Or it's usually not the case?
No, we do try intravesical treatment. Actually, the intravesical treatment is more directed towards the symptoms rather than the infection per se. We would treat all these patients like a chronic cystitis or an ICPBS. So the cocktail that we particularly use is that we use 25,000 units of heparin, 7 mL of lignocaine with 7 mL of bupivacaine, and hydrocortisone 100 milligrams. So this cocktail we instill weekly for 6 weeks. So this is particularly not directed at managing the infection, but it definitely has heparin. And these patients who have recurrent UTI tend to do well with this particular cocktail. So I'm again putting this on record that these patients are not classically interstitial cystitis. These patients have been having cystitis, infective cystitis, culture proven on many occasions.
Yeah.
So our experience is that these patients do very well with this particular cocktail.
That's very interesting. And the cocktail, I think it's published many years ago, this particular cocktail you're saying. And I know that in some hospitals in UK, we have used, a lot of it is DIY sometimes. And once it works for patients, you stick with it.
Yeah, agreed. Okay, so she had began the second 6-week cycle of the installation, but after 2 weeks, she contacted us, said she'd had 2 UTIs in 2 weeks. We didn't have any cultures at that stage, and she was seeking an alternative prophylactic regime, but we were running out of options at this stage, as I've shown you the evidence-based options, non-antibiotic options for recurrent UTI. So we were getting really down to limited options. And next slide, please. In this case, we used quite a novel invasive option for a pre-menopausal woman.
So I'll just ask Rajan here. I know you both are in the same department. Rajan, I mean, these intravesical therapies, does it have to be driven by the doctor, or in some places, I mean, I know in Southampton, it is all nurse-led and nurse-driven. What is your take on it? I mean, because sometimes when you have a nurse clinic, especially for something like that, they can sometimes give a bit more time, and also they can sometimes discuss other things, and so on in a bit more detail. What do you guys do in Newcastle? Sorry, Rajan, you're on mute.
Yeah, I was going to say the nurses are very invaluable to our setup. We've got 3 sort of functional urology nurses who help us manage the workload. And generally speaking, once you've discussed the treatment, they would go off and have the treatment over the course of a few weeks with the nurses. And they generally tend to stay with them for quite a while. And they would only let us know if the patients are running into trouble. So I agree, they probably get a lot more support by the nurses. And because they're going quite regularly for these treatments, they do develop a rapport, whereas they generally tend to see us once every few months.
Yeah. Sorry, Chris, I'll let you carry on.
No problem. So at this stage, we talked about intravaginal estrogen. Now, you may think that that's unnecessary in somebody who's premenopausal and will have a well estrogenized vagina. But we talked about it with the patient, and particularly she was more and more convinced that her infections were associated with intercourse. So we gave her a try of Vagifem pessaries, which are a vaginal estrogen preparation, to use every day for 2 weeks, then to maintain on a dose of twice per week. I reviewed her at about 12 weeks, and she said she'd had no infection. She was really pleased. I reviewed her again 3 months later. She'd had a single breakthrough urinary tract infection. She'd obtained a culture. This time it was an enterococcus, showing again change in the predominant organism. She was given 3 days of an antibiotic. I think it was amoxicillin, and her symptoms then settled. I reviewed her at 1 year following starting the intravaginal estrogen, and she'd had, apart from that single breakthrough at about the 4 or 5 month period, she'd had no further urinary tract infections. Absolutely delighted. So I thought this case gave a good insight in terms of the range of non-antibiotic options that can be tried. Secondly, the fact that not every non-antibiotic option will suit every individual. So sometimes you have to try a plethora. And in this case, we had to try 3 or 4 options before we settled on a treatment. But I think it raises the point of what people think about using intravaginal estrogens in premenopausal women. Are there any dangers associated with that? When should we stop the treatment? She's gone 1 year now with a single UTI. So I think those are the kind of points that I hope this case has brought out. Thank you.
Thank you, Chris. So if I can ask, actually, Rajan, first of all. Rajan, I have always been a bit worried about giving estrogens for long, because does it increase the risks of, other cancers, etc.? I know the risk is minimal. How do you go about counseling, and what are the symptoms, or what things you would ask and rule out before you put them on estrogens, or can you put them on straight away?
Yeah, I mean, I must admit, I would generally tend to use them mostly in the post-menopausal women phase. I think this case illustrated that you can use it earlier on, but especially, as you said before, previous history of breast cancer would be the main thing you'd be worried about in these women.
Yeah, but if you have, so Chris, you nodded there. I'm going to pick you up very quickly on it. If they have a history of breast cancer, is it a complete no, or does it depend on the time frame?
No, I don't use it in patients with a personal history or a family history of breast cancer. So I just don't use it. I wouldn't want to take that risk.
Perfect. So just for the audience, anyone, if you think of intravaginal estrogen, anyone with a personal or family history of breast cancer, generally speaking, you probably try and avoid the use of estrogen in them.
Yeah, and I think just to qualify that as well, I would generally avoid intravaginal estrogens in premenopausal women for the reasons that have been discussed. But I think if you're getting towards the end of the line, as we were in this case, as long as the patient understands the risk and you can document that. So in my clinic letters are full of lengthy detail about the discussions we'd had, etc., etc. I do think it's important that you at least document it. You know, at the end of the day, you can offer any patient any treatment as long as they understand the risks fully.
Absolutely. So just to say, I mean, if you did, Zafar, start them on, let's say, any non-antibiotic treatment, when do you stop it? Because this is a big dilemma, because you start it. Do you wait for 3 or 6 months, or once they've started 3-month period of no infection, and then so you can stop and see how you go and maybe restart? What is the stop and start points?
I guess it's that you're asking a question that's quite hard to answer, I think. I think in my mind, there is no start-stop criteria for a certain treatment. But the one paper that inspires me, I'll sidetrack slightly, is from Prof. Malone, who looks at each patient individually and tries to understand their own course and try and develop their own criteria.
Proudly, I must add, he was from Southampton. I must add, he was from Southampton. He was from Southampton, so proudly I must add that.
Okay, lovely. So, I mean, I would say that you need to look at it on an individual basis, because the host response of each patient, each person, is very different. And that brings us back to the idea that the whole genome sequencing, the patient genetics, will all start to evolve. And there's already papers coming out that's going to make a difference, I think. So, short answer, based on patient response, trying to understand the host factors and articulating it accordingly. But I guess Chris would know much better than I.
Chris, so just to conclude, Chris, when did you stop it, and what is the long-term safety with these? Let's say the patient is post-menopausal, so that takes this out of equation. When would you stop it? Would you? And then what is the long-term safety for it?
Yeah, I mean, I think in postmenopausal women, the long-term safety of intravaginal estrogen is very good indeed. I don't think we've got a concern about that. With this particular case, I saw her at 18 months and stopped it, and that was 2 months ago, and I've not heard from her, so fingers crossed. I do think that once you maintain a patient infection-free, they do then almost replenish their own innate defenses. So things like the GAG layer that gets breached and disrupted every time an infection happens, you know, the whole immune response goes down a little bit. So I do think, as Zafar says, you can individualize this. And many of the patients don't want to be on the treatments, but likewise, they don't want breakthrough UTI, so it is a fairly individualized decision. But I do always try and get them off treatment, especially if they've gone a significant period without an infection.
Thank you so much, Chris. I realize we have run over time, so I have got a case, but I think we have already had a lot of good cases that was discussed by Dr. Sinha, and really it has been great to see the journey of UTI in different talks, from basics to complex infections, to the prophylaxis that Abhishek covered very well, to genetic origin TB, and then the modern day UTIs and what is coming next. Guys, I'm really, really pleased to have you all on board.